Hear us, Judy?
Yeah, now I hear you, and you can hear me, right?
Correct.
Okay, great.
Correct.
Got it.
So when I'll start over because this is a new group of people, Judy, that from our first meeting.
Okay.
So we're going to start over again. We're going to repeat, do it again. But a while back, maybe 6 months ago or so, I was reading on some ACNM board thing, a conversation that Judy had started, I believe, and it was her talking about how she could prevent postpartum hemorrhage with her technique, and it was a lively conversation between midwives and her. Like it was midwives had questions. Why do you think this works? Why do you not think this works? And it was, what about this? What about this? What about this? But anyway, I found it fascinating. And I also found that I felt like it was something that midwives in general were hungry for, very interested in, really wanted to learn about. And so I just had an idea that we should actually talk to Judy and hear what she had to say after all these years. So she's going to introduce herself, but she's been a midwife for a really long time and been doing home births for a really long time. And has not had postpartum hemorrhages for a really long time. I find, for us at least, it happens on the regular. It happens regularly for us, not so much, but I mean really big hemorrhages kind of on the regular. So I have been trying out her technique, not exactly the same as she does it, but I have found it, I found that it really works kind of amazingly, and have had blood losses, of 50 cc's, 100 cc's, 150 cc's, and then sometimes a little more, but no hemorrhages, Judy, no hemorrhages yet. So anyway, go ahead and introduce yourself. Tell us about your life and your work, and then how you got to this almost zero hemorrhage rate that you have right now.
Great.
So
it is zero. It is
zero.
Zero, less than 500, not less than 1,000. So I'll try and be fast because I hope that you'll ask questions at the end. I'm a CNM with a master's, educated in America. I have a bachelor's in biology from Cornell, a bachelor's in nursing from Columbia, and a master's of science in midwifery from the University of Minnesota. And I have 4 kids, and I delivered 6 of my grandchildren. I worked 2 years in hospital, and then I started my own home birth practice. And I want to hear at the end how Lisa has adapted. But remember this, I've been honing this protocol for 20 years now. So 20 years ago, I had a woman who insisted on delivering the placenta and squatting, and it came out easily with very little bleeding, and a light bulb went off in my head and said, let me try this. So I did, and I kept getting much less blood loss than previously. And after the first 250 births, I wrote a letter to the editor and got it published in Birth Journal, which is a pretty good journal, in 2010. And I asked at the end of the letter, would people try it and write to me? Because I didn't know if I was onto something or not. And nobody wrote to me. And after 700 births using the protocol, I published it again in 2017. And then after 2,100 births, I published it again, innocently believing that the world would be interested in a way to prevent maternal death, which was a protocol that cost nothing. I was wrong. 10 years ago, I changed the protocol from delivering at 5 minutes, which I made it myself. Just I was educated like all of you. Wait for till you see a spurt of blood and then deliver the placenta. And so I was winging it. And I said, the first 10 years, I said, okay, 5 minutes, because like you don't want to disturb the woman. But I saw such great outcomes that I changed it to 3 minutes, meaning the woman squatting at 2 minutes and delivering the placenta by 3 minutes. not only is the placenta separated by 1 minute, but if you squat, it's delivered by 3 minutes. And now that I've done this over 1,000 times at 3 minutes, there is absolute proof. The placenta is separated by 1 minute, just as it says in the textbooks before 1990. The reason to cut the cord at 1 minute is because it's no longer functioning and it's easier to deliver the placenta with the cord cut and putting the baby either in the hands of the other partner, or putting it on the bed. And delivering the placenta quickly eliminates uterine atony, which decreases blood loss. So that's a topic we'll probably discuss in questions. If you wait more than 5 minutes to deliver the placenta, you and everyone in the world will have 5% PPH rates over 1,000. That's been documented countless times. 95% of your births will lose 500 cc's, or a little less, hopefully, but that's the average blood loss documented in research. And recently, in an effort, because now I really want to promote this myself, because I see the medical world has zero interest in eliminating PPH. So you have your bottle of ketchup. It has a little bit of ketchup left, right? The baby's out. Most of the ketchup is out. Now you've got some ketchup left in. How do you take that last bit of ketchup out? Do you hold it like this with the woman supine laying in bed? Do you expect to get it out? And how hard do you have to push then? Or do you just, everyone holds it like this and they use gravity to get the ketchup out. And this is absolute what you're doing. When you get the woman in squatting, you're using gravity, and it's a better use of your muscles if you go like this than if you go like this. And I couldn't be simpler. And when you start using it, you're surely going to say, wow, I can't believe I didn't think of doing this before. And this is so simple. And why isn't everyone doing it? So if you want a 1 minute description of the protocol that I use, is at the last visit with the woman, I tell her, oh, you're going to deliver the placenta in squatting because you'll have less blood loss and no hemorrhage. And I usually squat in front of her because the word for squatting in Hebrew is not so clear. Some of them you have to use the English word. So I want to make sure they understand. So if you have any language barriers at the birth, you have to have a digital watch. The baby comes out, and I immediately look at my watch and read the digital watch. Okay, 2:02, and I usually say it out loud to help me remember it. And exactly 2 minutes. So at 2:04, I say, oh, very calmly, please, you have to get into squatting. And almost all women say the same thing. Oh, I'm really too tired. And then I say very calmly, well, you absolutely won't have a hemorrhage and you'll lose a lot less blood, and you'll also get the whole thing over with, and you'll have much more bonding with the baby. And they all get into squatting, with the exception of one woman I had who was 300 pounds and doesn't squat. So, and it worked every time, except for, as I documented, 0.7%, which is 7 per thousand, needed a manual removal. The first time I needed the placenta didn't come. Oh, if it doesn't come by 15 minutes. The first time 20 years ago, I waited half an hour because that's the usual time that you have to transfer. And then, to my surprise, I put on a glove and I did the manual extraction myself because she was a good hour plus from the hospital, and I knew that would have a worse outcome. Plus, I asked her, I said, well, what do you think of me doing it? And it was a first birth. It was placenta accreta. I separated it from the wall. I pulled it down. There was also hardly any bleeding, and she didn't take antibiotics. She said she insisted on eating a lot of garlic. She wouldn't take antibiotics afterwards. And that's what I did. I'm a CNM. I was definitely not trained to do manual extractions, but they're very easy to do. Afterwards, in the hospital, I know they do it under anesthesia. So I asked her, did it hurt? And she said, no, not at all. It just felt weird with your hand inside my uterus, deep inside my body. So how does this protocol works? It works because gravity, the abdominal muscles are more efficient in this position, just like pooping. It's easier to do it when you're squatting than when you're laying down. And also because you're delivering the placenta quickly, so the cervix does close down rather quickly. As you've definitely all seen cervixes close during labor. A woman gets tense and suddenly it goes from 10 to 5 centimeters. I mean, I've certainly seen that. So you're delivering it, 3, you're delivering it before the cervix closes, and 4, you're delivering it completely because gravity helps it all come out instead of leaving some pieces inside, which in the hospital they get about, I don't know, between a few percent of placenta left inside. And I absolutely guarantee that you will never get a postpartum hemorrhage if you do this simple protocol. You only have to try it once, and I hope you all do. So now some questions. Is everyone gonna, yeah, Janice. Oh, you have to
turn your
turn on your microphone. Yeah.
Hi, Judy. Thanks. That was the first thing I said. And is cutting the cord a part and parcel of this protocol?
So, of course, I have the same population as you guys. I'm doing home births, so I get a lot of women who don't want to cut the cord. So I've done it without the cord cut for sure. The baby, the cord is only so long, so the baby's laying on the floor on a blanket or whatever you want to put down there. As the placenta comes out, there usually is a splash of blood. So then the baby gets splashed with blood. And then the mother gets into, the mother cannot do it holding the baby, cannot do it. Don't think that you're going to, reinvent the wheel. It's been tried. I've tried it a lot. Mothers cannot push out the placenta while holding the baby. I'm sure there is one superwoman who can do it, but I've tried it many times and it doesn't work. And you remember, you're looking at minutes. You're looking at seconds here. We're delivering the placenta in 1 minute. So now that I'm very confident because I've done it so many times and I'm an old midwife and my clients like me, and I say, look, the placenta, the cord is not pulsing. Look at all the coagulated blood. See that purple dot? See that purple dot? Nothing's flowing. Can I cut it now? And it'll make it much easier. You'll bleed much less. You'll have the baby in 1 minute. You're holding in bed and you can nurse it. The baby is not getting anything. And so it's been a while since I didn't convince a woman that she's listening to the wrong people. This whole delayed cord cutting. I've read all the research that I've come upon. Delayed cord cutting is cutting the cord at 1 minute. And you can tell them all the research defines delayed cord cutting as 1 minute, except some crazy stuff that doesn't define it at all. That says, oh yeah, we waited a while, but the original stuff, when they compared immediate cord cutting to delayed cord cutting was at 1 minute. And the placenta has detached by 1 minute. And that's, I've done thousands now. Every time the placenta came out by 3 minutes. So you cannot tell me that the placenta is separating at 5 minutes. No, there's no way. So you should try and convince them to cut it at 1 minute. If not, it's just very not aesthetic to, it also wastes time. So now I have a baby that has blood on its face, which most people can't handle at all. So now I have to actually take the baby somewhere where I can wash it and then give it to her and dry it. And it's not convenient for sure. But I've done it. I mean, of course, I have had women who wanted lotus birth where they never cut the cord and did it. So, but they can't hold it. They cannot hold the baby and push it out. You're just losing time, and then you're gonna say, "Oh, the protocol doesn't work." but it does work. You know what I do? I should mention, I've never, only because I'm talking to midwives. I actually don't cut it. I don't do the final cut. That I cut it somewhere for expedience. So somewhere along the cord, I use a clamp, and I put the plastic in a clamp, and I cut it so it's very, very quick. And then before she gets up to go to the bathroom at 2 hours, I used to put a plastic clip close to the umbilical cord and then cut it close so it would look nice. But now I actually use a string because I find the clip after a few days, it bobs back and forth and causes a little bleeding. So when I say cutting the cord, I'm just cutting it random somewhere in the middle, leaving as much as, I don't even care how much I'm leaving, just cut to get the baby out of the way, because getting the woman into squatting takes some cajoling, because I'm quiet, oh, you have to squat. So I spend zero time trying to get an aesthetic clamp on the cord. I just clamp it anywhere and then later redo it. And I like the string. It's a very, kind of a 6-string, but that's very nice. And people really like that because then it doesn't wobble and it doesn't pull and the baby has less bleeding later. So, but that I do like at 2 hours after. I hadn't ever.
So my variations on this, what I've done is just try to get the placenta out way sooner. And I've told Judy, but my biggest problem right now is everything written on the internet about waiting until the cord is white. So our patients all want a white cord. And I'm like, I don't even know what you guys are talking about. Like, why do you care about that? But they do, because they've read it and they feel very strongly that they don't want the cord cut. So most of the time, not all the time, I've delivered the placenta very quickly, probably within 5 minutes, Judy, more like 5, but without actually cutting the cord. And I'm not saying that I haven't actually clamped it. I've clamped it, but they don't even know the difference of that. They don't even know what they're asking for. They're just like, don't cut the cord until it's white. I'm like, fine. So let's just get the placenta out and then we can wait for that part, and they're real happy with that. So I really, because I knew before I ever read this from her years and a million years ago, I would feel the cord. I would still feel a pulse. After a while, I would just get tired of waiting. I'm like, oh my God, it's been so long. I'm just, okay, it's done pulsing. I just say to the patient, it's done pulsing. Cut the cord and say, push the placenta. And the placenta would come out as if it were in her vagina. So I knew that the cord was pulsing, but it was just the baby's pulse I was feeling. It wasn't, referred, I guess, or something. It wasn't actually doing anything. There was no actual blood flow going on back and forth between the mother and the baby any longer. If I could get the placenta out in seconds after I told her to push, it took, it was sitting right there, literally right there. So, so I do think, and I understand what the not delayed cord clamping was. I mean, I would stand at a C-section, the baby would come out and they would clamp the cord before. I mean, it's so fast. So fast. The baby would come out, clamp, like as if they didn't want one drop of blood to move at all between the mother and the baby. But the delay of that 1 minute, like when they take their first breath, then the blood should flow quickly, very, very quickly from the whatever's in the placenta into their lung fields, however much they're going to get. It shouldn't take longer than that minute. Like they should all be crying by a minute, at least breathing deeply. And they should all have gotten that little bit of blood, whatever that is that they get, that should have happened already by 1 minute. So I believe all of that. It's now trying to undo. We're trying to undo what's been done online by people.
So I always discuss it with them, and the ones who are extreme, you can't move, I say, okay, I'm not going to cut the cord. The ones that I can move, you can, and are rational, I explain to them. The placenta's detached, so it can't be bringing any more oxygen. Another argument is if you've ever taken cord bloods for germ cells, well, back when we were, so if you ever had to do that, by 1 minute, you can't get anything. I mean, you need, to do it, you need at least 80 cc's. You have to get that needle in so quickly to get even 50 cc's. That cord is not working. Third, as soon as the baby starts breathing, the cord circulation goes offline. There is no way for two-way for the baby to get oxygen from lung circulation and cord circulation. And finally, this myth is based on this. There's the research that says the baby gets a third extra quantity of blood, and that's why you shouldn't cut the cord. And that's what my women are usually repeating, that the baby gets more blood. So that is based on a mythical idea that at birth, this cord, which is going to the baby and from the baby, suddenly turns into a one-way system that only goes to the baby and brings the baby 100 cc's in a minute or 2 or 3 or 5, and none comes back, which does not happen. There is no evidence of that. And secondly, you would not want that to happen, because an extra 1/3 of blood volume, the baby has to get rid of all that blood, because by day 3, when it goes jaundice, it's getting rid of all its fetal hemoglobin and turning it into adult hemoglobin. So you wouldn't even want the extra blood. And I don't know how those articles passed peer review, but I'd be happy to write a review, but nobody's publishing reasonable research anymore. So I'm not going to waste my time on it. Unless somebody asks me to. And plus publishing research is now $3,000-$4,000 in articles. So you can convince women with those arguments, anyone rational, and say, where's the oxygen coming from if the placenta is separated? And do you want your baby to have to dump extra hemoglobin on day 3 and turn jaundice and be under the lights? I don't know. These babies aren't under the lights, which is proof that the cord is no longer functioning. But it is and I explained to them that it's a reaction, that we had immediate cord clamping for so long, and it's a reaction to that. But you don't have to exaggerate and do something that's dangerous in reaction to what they used to do.
Right. So I have had them just sitting in the tub. Judy doesn't do a lot of water births, but I've had them sitting upright in the tub and just said, after a couple of minutes, push your placenta's detached now, push it out. And then they just push out their placenta, like literally just sitting right there. They just push it right out. Or have them get up.
I do a lot of water births actually, but I always let the water out.
Okay. And I've had them get up in the water and squat, still holding the baby, and push out their placentas. The problem is if the cord is short, it's hard to do. And so I haven't quite gotten to the point yet where I've actually clamped and cut the cord so early, but I've had the placenta delivered very early. So my third stages have gone, I've probably lost, most placentas are delivered, in my experience, in 10 minutes, maybe 12 minutes, maybe 15, but I've got them down to like 6-7 minutes. So I've been just playing with it. I haven't actually truly done it. And I am planning to, because there's been so many times where I've waited for a placenta, for any sign of the placenta being detached, the kind of the classic thing that they taught us in school, or taught us, so I learned somewhere along the way, to brace my hand against the uterus by the pubic bone and then pull on the cord to see if it was detached. Is the placenta detached? And And I would be like, no, it's not detached. No, it's not detached. And now I'm thinking that maybe what I'm feeling is a placenta that's stuck behind a closing cervix. And that's why it feels like it's not detached yet. But basically what it means is that it's not out of the uterus yet. And it needs to be out of the uterus. You got to get it out, because many times the placenta will come with a river of blood, with so much blood I felt the uterus rise in their abdomen, like I know the uterus is filling. Like I think that there's a lot to be said for getting the placenta out. So
yeah,
I've had a lot of really success with not even doing it exactly right, Judy. So that's why I think I've got to start a whole policy or education for the patients ahead of time, because I don't know. I think that you probably have in your world such a reputation for being such a wise and skilled midwife that they probably listen to you more than some of my patients who believe that they are actually obstetricians in their other life. And so they know everything more than me. And so they need a whole new education in their prenatal care about a way to prevent postpartum hemorrhage. So
no, I don't think that. I think women are the same throughout the world. I want to really emphasize two things. And the 0.7 per thousand, where I've done manual extractions, does follow what you're saying. So half of them, the cervix was right, the placenta was right behind the cervix. And why didn't it come out? It does happen that women are just too tired. They just sit and they squat because I'm making them squat, and they just say, I'm trying, I'm pushing, and they're not pushing enough. And actually one was my own daughter, who's a doctor, who I had to do, she just was exhausted. And she pushed for a long time on one of her births. So 3 or 3.5 per thousand, it's just behind the cervix. But there is a case where the woman is just too tired. And if you wait, so she's bleeding inside. And what are you waiting for? And the other half were accretas. And one of them was, I just want to share all my much experience. One of them was a first birth. The first one was a first birth, which you don't expect. You expect it on the VBACs. The VBACs were generally okay, although I think there was 2 or 3 manual extractions on VBACs. But if you don't do anything, it's true. Most of the time, everything will work. So why did I especially move it down to 2 minutes? I've had 3 or 4 of these, but one woman came to me. Her history was this: 3 births. She had postpartum hemorrhages of 1.5 liters, which means in the past, which means she got blood. She was very weak. They told her, she's got something wrong with her. And she homeschools. I guess she's nutty enough to look for me. And she found me and she said, will you deliver me? And I met her and I talked to her and I said, you know what? I will, but I moved it up from 5 minutes. I said, there's something going on. We don't know. I mean, her blood tests were fine. It wasn't her platelets. They didn't find something particularly wrong with her, but she's got something. And that's when I moved it to 2 minutes, for her actually 1.5 minutes. At 1.5 minutes, she was very cooperative. I said, you don't want a hemorrhage? Get up at 1.5 minutes. And she had that placenta out without a hemorrhage, with not excessive bleeding. So under 500, I'd have to look up her chart. I don't remember exactly, but I think more like 300, not even 500. And that's when I said, look, if it works for her, what are we waiting for? The mother, once the placenta's out, she's got wonderful bonding. She's laying in bed with her baby, nursing. She's done. And I don't touch the uterus. When I deliver by 3 minutes, I don't do any massage. Of course, I don't give any drugs. I just get her into bed with a pad on, and it works. And so that's when so I agree with you. You will get, Lisa, I believe you. But if you do semi-high risk women, and they come to you with a history of humongous PPHs, which the doctors say, oh my goodness, you certainly can't have a home birth. And you can deliver them, but you have to really, really have their cooperation and say, I know you're tired. Now get into a squat and push. And it will be out in 1 minute, and it's out in 1 minute, and you get into bed and you're just like everyone else. So I just want to share that in case that happens to you. Now, you might not take these women either, but the VBACs are also high risk for bleeding. And I think it's emotional, right? They don't believe they could do it. The baby comes out, they're in shock. Some of them are literally in shock and can't talk. They're just like, and I want to get that placenta out the same as everybody, or even more so, because it's a VBAC. There's a scar. You don't know what's in there.
I have a quick question. I have my hand up. I don't know if you see it, my hand and Sonia's hand. I wanted to ask you, what do you do if people are on medications, whether they're IV medications or other things like that? Is there anything different, or are you just not, that's just not something that we can consider?
So none of my women are on IV medication, but half my women take Rococet, which is an Israeli drug, which is codeine, 10 milligrams of codeine, Tylenol, 500 milligrams of Tylenol, and 30 milligrams of caffeine, which I think gives them a little bit of energy. And that's an over-the-counter drug here in Israel. And half of my women take that, and that takes the edge off. And of course, so that's half my women, so it works fine. IV medication, I guess you have, it's been so long since you're talking about one dose or like a continuous drop?
Like Stadol or something like that, some sort of narcotic.
But they take it once, right?
Yes.
So it's already wearing off from the pushing, right?
Maybe.
Maybe it'll work the same. The
Okay.
placenta is separated. Now you might have harder trouble getting them into squatting, but this is a doctor criticism. When I work with women, they don't want a hemorrhage. That woman on Stadol, she doesn't want a hemorrhage. So you just say, look, you get into squatting. It's going to take 1 minute. You're going to have to push, and you're going to be done in bed, nursing your baby. So, and I haven't had objections to avoiding hemorrhaging, a little bit more with women who never gave birth before, but I explain it to them.
Mm-hmm.
It shouldn't be different. I mean, I usually arrange where they're going to squat. So either two hands on the bed, or a hand on a chair, hand on the bed. They're usually near the bed, or the bathtub is really perfect. I always let the water out of the bathtub because it's not helping them anymore. It hurts a lot to deliver the baby. I've delivered myself in water. It does not significantly help to be in water when the baby comes out. It's not like you don't feel anything. It's not like, heroin. You feel it. So I let the water out. I don't ask them. They see they're a little out of, they're pushing, and I take the plug out and let it out. It depends how long I think it's going to take them to deliver, but if they're imminently, I let the water out. If it's going to take a while, I leave it in until it's imminent. I mean, I'm usually working in bathtubs. The pools, there's nothing you could do. They deliver in the pool. And then I say, I'd like you to get out. And usually they do if they want to, I don't know. I've also had bad experiences. I mean, with non-cooperative women that
Who had a question? Who was it? Casey?
I have a question. Does it have to always be a squat, or can it just be upright? So if they're getting out of the tub and they're standing, is that fine? If they're kneeling, is that fine? Or if they're on a birth stool, or does it specifically have to be a squat?
So standing, it won't work. None of those other than squatting. The only thing that will work a little bit is standing, but you don't think about pooping standing or pooping squatting.
Right.
You know, it's much, and we're looking for, so 95% of the time they could stand on their head. What we're trying to prevent is the 5% hemorrhaging, and you don't know who that's going to be. So why entertain them? You know, it's for their benefit. It's not for your benefit. You don't care, but they should care, and they can get it out. Obviously, all animals squat. They don't stand to deliver the placenta. I don't believe it. I believe they squat. I've looked and searched for YouTubes. None of them show the placenta coming out, but all the monkeys and chimps, they're always squatting. Some of them are they're moving around, but at birth they're squatting. So why? Because they want to reinvent the wheel? If their hemoglobin, again, if their hemoglobin's 13 and 12 and they're not worried, I don't know, you could play around with it. My clients in Israel, we don't have, most of them don't eat red meat. Some do, but very, very small percentage. So I'm usually dealing with a hemoglobin of 10 at the beginning of labor. So I really want what's best for them. The chair, no. It's really, squatting is some, you know that there's a squatty potty, you know, so that also works. It's kind of amusing, their advertising. Like a total aside, because I'm 70 years old, right? And I have 4 kids. So at the end of 4 kids, you usually have some urinary incontinence. And since I've been peeing in squatting outside, like once a day, I can sneeze, I can cough, I have no leakage at all. What is going on there? Exactly. Like, what's so different about squatting to pee than to sit on the toilet? It feels about the same. But I can tell you that's for sure how you could go from 60 years old to, you know, where you sneeze and urine comes out, to being 70 and never ever have it leakage. There's something very special about squatting, and I don't know what exactly.
Judy, thank you so much for having this session with us. I'm finding it remarkably educational. So I'm Sonia, and also I hope you're very safe right now. I know that the world is crazy in Israel, and I really hope that you're safe. And again, thank you, because I'm sure that it's hard to prioritize a conversation like this right now. But can you perhaps talk a little bit? I deliver in a hospital and birth center setting. Do you ever talk to hospital-based midwives about, techniques that they can use? I can just see the docs saying something like, "Oh my God, you're going to have like a uterine involution because you're not guarding the uterus," and all of these things, you know?
Okay. I've been at this for 20 years. Mm-hmm. There is no avenue I haven't tried. Mm-hmm. And I have gotten nowhere, not anywhere with doctors. And I recommend not going in that direction after 20 years of, and publishing and lecturing at hospitals, and the same with hospital midwives also is my experience. So my son and I went to a lecture of Gad Saad in Tel Aviv. He's evolutionary something, and we asked him, and my son stood up and said, "Oh, you went to Cornell. My mother went to Cornell. She has over 100 first author publications. She's published this protocol which saves women's lives." and she's not getting anywhere with it. What do you recommend? And he said, this is the Semmelweis reflex. Doctors don't want to promote anything that goes against what they think. What you're actually saying when you or I approach the doctors, you're saying you're a murderer of women by using your protocol. And here is a protocol which will save women's lives. This is what you have to do. And that's what Semmelweis did. He said, you're killing women. Just wash your hands. And what happened to him? He ended up in a mental institution and died there.
Yes.
So this is a Semmelweis reef. So you cannot, I agree, I really have tried everything. You cannot approach the medical establishment. So that's why after talking to him, we made a website, Gravity Medicine, and it includes that a woman gets the doctor to sign, you are going to let me squat. And this is the only direction. You're only going to get this in the hospital by the women demanding from the doctor to sign the, you'll see it on the website, the permission to squat. And then if they don't let them squat or they don't remind them to squat and they have a hemorrhage, it says, and now we know that they are liable. And I know it may sound terrible to you, but that the only way after all these years, I've been writing to ACNM. I've tried to publish it in every journal, including, of course, Journal of Nurse Midwifery wouldn't take a letter to the editor. They wouldn't, every year I applied to talk at convention. No. And even those crazy, the International Conference of Midwives over the Zoom that they have, they rejected and you'll try it once, you will see it's obvious, it works.
Do you have any, have you ever talked, so I'm just trying to think for women who have epidurals, we can move them. There's a bar, they can hold on to the bar. It's possible. It's not that it's like impossible. It's just more challenging.
I know 2 women with epidurals that did it. They used that they delivered with me and they went to the hospital and had an epidural and they hung on the bar with help from the midwife and insisted on squatting and they delivered the placenta that way. But only 2. I went to Zeev Hospital in Svat and because I had connections with the head of the department. I gave a lecture. I said, I got the testing protocol, which I would Lisa has it. I'd like to send it to all of you. I'd like you to document your outcomes. I'd like to, if all of you do even 100 births each, or even 50 times 9, we're talking 450. And then we have different practitioners. And that is a much more strong thing to publish, although the publishing doesn't seem to impress anyone, but let's do it anyway. And collect their data. So I went to Zeev and I said, come, we have to do a hospital test. I want to do a hospital test. I want to see how we could do it with epidurals. And we talked and I demonstrated and they said, yes, we think we could do it on epidurals. And the head of the department we were writing the protocols for the research and he said, no, I don't want to do it. So why? I don't know. I followed up.
Judy, can I ask, please, do you do any cord traction when they're pushing out their placentas?
Yes, I do.
Okay.
I do. I do it gently. If you do it hard, the cord will fall off.
Right.
So usually I wait. So I've got them into squatting at 2 minutes and I don't do anything. Usually I'm even on purpose away from them for a minute to give them space and to make them feel you could do it. I maybe say, you can do it. You can do it. Keep pushing. And I say, no, push harder. It's going to come out. Not even looking, unless they're super high risk for some reason, and which is rare. And then at 3 minutes, if it's not out yet, I come over under them and do gentle cord traction to pull it down. Like if it's an anterior top placenta, it's sticky, and and you feel it kind of coming, hopefully, and then your heart goes in, you know, and you go, oh my gosh, this must be an accreta. I don't feel anything moving. And then you do a little bit more, and I say, push harder, and it comes a little more, and it comes out. So definitely, I should really write down, if I would say half the time I do gentle cord traction, definitely. And that's why Lisa said, you know, I really should have a video, but I don't have any videos of me doing it because half the time I'm trying to like be very cool so that they feel like they did it themselves. And then at 3 minutes, and they're of course like, don't touch the cord, which is part of the same, don't cut the cord. Oh, don't touch the cord. Don't pull on my cord. And I say, you know, I won't. And sometimes I do anyway, because you're usually they can't really see what you're doing.
Do you guard the uterus while the placenta?
I have not touched a uterus before or after literally in years.
Right, which is what we were trained. Lisa was mentioning it earlier, that how we were trained, you guard the gentle cord.
I was trained the same way, and I slowly let go of it. And at first I did. And how about the much more pressing is that after the placenta comes out, you give one good squeeze, because I'm not giving Pitocin. You either give Pitocin or you clamp down on the uterus. And I used to do that because that's what they told us to do.
Mm-hmm.
I don't do it. I don't. It's when it's that since I've been out by 3 minutes. I don't touch it. Now I barely even look at the blood loss because I know she's not going to fill up a pad in 2 hours. I mean, and I always look at it at 2 hours just for the sake of, I always write down estimated blood loss for every birth. But you know, the uterus knows what to do. But especially by 3 minutes, I like it. And why? What are you doing for those 5 minutes? The woman's kind of out. She's still laying in bed, and she's not usually nursing, and sometimes she is. Sometimes the babies attach at 5 minutes, but usually not before, usually not at 2 minutes. So she's just looking at the baby. The father gets the baby. He's really into it, like, because the baby is very special immediately. Like, if there is something different about the newborn than even 2 hours later. And usually they're quite alert. And it's 1 minute, and the mother does her thing. And you say, you'll be done. You'll just push. You'll be done. You'll be in bed, and it'll be great. And what are we waiting for? You know, what are we risking? I'm usually my births are quite far from the hospital often, and they know it, and I know it. Like,
go ahead, Casey.
Yeah, I'm thinking of a way of framing it when having the prenatal discussion with women is to make sure they really understand that the placenta is part of the birth. The birth is not over, and so you're still doing birth things until the placenta is out, and getting into the squat is the position that you get into to have the placenta, and then the birth is over, and then you can lay down with your baby.
So after all these years, you know, my women come to my house usually. So I'm years and years of my husband yelling at me, why do you have to talk to them for 2 hours? Well, can't you, you know, he's pushed me. Okay. So here's my discussion. Why do you want a midwife at the birth? And I say, you know, I only really have 2 functions. One is 1 in 100 babies have to be resuscitated, and I'm an expert at that. And 2 is preventing postpartum hemorrhage. Those are my jobs. And that's why you're hiring me. In addition, if the baby is very large, then I might have to deal with a shoulder dystocia or a macrosomic baby that's hard to get out. But really, if the baby's 3 kilo, those are my 2 jobs. That's what you're hiring me to do. So, and I figured out how to do it because I want the best outcomes. And that's in a nutshell what I, to keep the prenatal visit. Sure, then they can ask questions, but that's what you're hiring me to do. And I know how to do those 2 things. And otherwise, you want to deliver standing on your head, anywhere, outside, in the pool, in the bath, do whatever you want. I won't disturb you. I won't bother you a bit. You're gonna, and if not for those two things, then you could deliver unattended and have pretty good outcomes, except for 1 in 100, the baby will die, and 5% you'll hemorrhage. So is that sort of give you a encapsulated, but I am, I don't know. I mean, that's personality, right? But women will keep you, right? I mean, I do try to get to the rest of the visit is getting to know them. What kind of hangups do they have? What am I dealing with here? How do they, hate their mothers? And also, where is their mother? And then they have a very long labor. And where's their mother? Who's going to take care of them afterwards? There's a lot of discussion about who's going to take care of them. I don't know why they want a home birth. It's true. Like, it can go on and on. But wait, did that answer what you were thinking? So that's my quick answer to why they should do it.
Did you say the last week or 2 weeks ago that there's no real documentation of other mammals hemorrhaging?
There is never, ever been a chimpanzee or a gorilla who hemorrhaged unless people were messing with them. There is no, and they have the exact same placental attachment as we do, the exact same genetics of the placenta. So there is no reason why any woman should hemorrhage, but you gotta, let your monkey do it. And I think the monkeys do. I can't say that for sure, but I think they deliver it really quickly, and then they eat it pretty quickly. I'd love to get it, that was her question, that they say, we're not interested in the placental delivery. So yeah, so that's my answer, that's half my job is the placental delivery. And I often remind them, I say, now I'm going online. Now is my time to work. So let's get this. That is my hardest thing. I have to get the placenta out. And yeah, like the more that you do it, it took me years, but the more you do it, the more confident you get. And the more confident you are, they feel it, especially the husbands. They say, oh, she seems to know what she's doing. Let her do it. And I recently, I had a woman who I delivered all her babies. So she's never delivered in the hospital. And she actually saw the GodSod interview lecture is on YouTube. So she saw it and she saw my son asking the question. And she loved it. And she said, yeah, I've never known anything else. So all my placentas were delivered in a few minutes. And I thought that's the only way you do it. So I hope someday everyone will be able to say that. So do you think you'll document it? Like, I'll send, it's a very quick, it just says your name and the risk factors of the woman and how long it took for the placenta to come out. But you have to time it, and you'll see it's not such a pain in the neck, but you need a digital watch. The other watches, after 2 minutes, you're always like, wait, was it 2:02 or was it 2:04? Like, what time was it on that watch? Whereas the digital, it's visual, you kind of see it and you say it out loud. Because it's a short amount of time and it's not. In those 2 minutes, the woman goes from not having a child to having a child, and there's a lot kind of going on. Is the baby breathing well? And so it goes fairly quickly for her. It goes, so you have to time it. But a digital watch is enough. So I hope you try it on the next thing.
Mhm.
And even,
I think we should. I mean, and I was wondering if I scheduled like question answer thing for next Monday, but I wonder if any of you guys and our other midwives would be interested in coming back and talking in another maybe month or something after you get a chance to try. I mean, I think Sonia, like just trying to have them push it out sooner, like just get the placenta out. I would wait 2 minutes and just say, all right, your placenta's attached, push it out. And that's it. That's all I said. And they just push it out. Like, and I'm like, oh my gosh, so, and the placenta come out and I put it in the pan, set it next to them on the bed and like, whatever, so many minutes later, I'm like, can we cut the cord? And they're like, is it done pulsing? I'm like, yeah, it's done pulsing. We can cut it now. Sitting next to you, it's not doing anything. Why would you think it was doing anything? But they still are so attached to that idea. But I don't care. I could cut it 2 hours from now. I don't care how long after it's out of their body. Upright as possible. And I mean, there are squat bars in the hospital. And I've been thinking about that, like that if we pull the squat bars out, which I never do post delivery of the baby, but I certainly could, and have them get up and squat